How is it that the wealthiest country in the world has such a screwed up healthcare system? After 35 years in the healthcare industry, I decided to retire and share my secrets with you. I'm Chuck Melendi, and this is Disruptive Dialogue. So I'm excited about our guest today. Dr. Madelaine Feldman is the managing partner with the Rheumatology Group in New Orleans, Louisiana. She is a nationally recognized expert on pharmaceutical drug pricing and patient access care, to name just a few. Her articles and opinion editorials have been published in major media news outlets. She's a highly sought-after speaker. She has testified in front of Congress, state legislatures, the Federal Trade Commission, and the World Health Organization. Dr. Madelaine Feldman is also heavily involved with advocacy efforts to have a positive impact on state and federal legislation aimed at fixing our broken healthcare system. However, I'm really excited to dive into the fact that you used to be the talk show host of a radio show called Driving with Dr. Mattie. I've known you a while.
Indeed.
I didn't know about that.
Yes, indeed. That was a while back, and you'd be surprised. I'm sure you know that now. How much time it takes to put together just a 1-hour show once a week. Much less, these folks that do daily things or put together daily podcasts. But thank you for having me here, and please call me Mattie.
Oh, thanks, Mattie. I appreciate it.
No doctors needed right here.
Well,
so happy to be here, Chuck.
Yeah, and I have to tell everybody in the audience, I'm super excited. Dr. Feldman, or Mattie, I've known her for a while. She is a rock star when it comes to advocacy. And literally to testify in front of Congress, to talk to the FTC, the World Health Organization. I feel blessed that you have the time to come on here and talk. I know a lot of it is because of the passion that you have for what we're going to speak about today, which is the healthcare system. But before we dive into that, just so everybody gets to know you a little bit personally, can you share? When I talk to guests, I love to find out, how'd you get into what you're doing? Was there like a turning point, something in your life? Can you share that with us?
Sure. Well, if we want to talk about how I actually ended up as a physician, yep. I was a theater major undergrad and actually finished with a theater and biology major. But during that time, unfortunately, my mother was diagnosed with lung cancer. My brother, who was a year or so older than I was, who was going to be the one that was going to be the doctor in the family, he actually joined sort of what was called back then the Moonies, which is kind of a cult. And so I went to undergrad here at Tulane in New Orleans. So I would accompany my mom to her various oncology visits. Now we're talking the late 70s. And, they didn't want to give patients pain medicine for fear of getting cancer patients addicted. And, it hit me really deeply that nothing against the physicians where she was going. It's just I kind of sort of felt like, well, maybe I can do better. I'm the theater major. I wasn't supposed to be the doctor. But if my brother could do something so unusual, why can't I be a physician? And so I added pre-med and consequently ended up with a double major in theater and biology. And I'm going to tell you, Chuck, I used more of my theater major than any of the organic chemistry I ever took.
Oh,
in my practice.
I'm sure you do. That's awesome. That's a really cool story, and it so many stories that I hear about how people went into the profession that they ended up, and how somehow life bifurcates and you end up where you're supposed to be. So
absolutely.
Yeah, thanks for that. One of the things that in my old role, as you knew me when I was with Johnson & Johnson, I worked with so many physicians, and I know that profession, whether people know it or not, is under assault. Can you share from a perspective of a physician what's going on with the practice of medicine?
I went out into practice around 1990, and things were much different then. They were starting to change. I'm a rheumatologist, so I take care of patients with autoimmune diseases. And back then, we had very few fancy medicines. Another word for fancy is expensive. But they were just sort of coming into being at the time. And, we would sit and we would talk with patients and we'd figure out, what the diagnosis is, and then sit and have a treatment plan. And, as years went by, the whole idea of shared decision making, which was a good thing, sort of came about, where it's not the doctor pontificating to the patient, you have this and this is what you're going to take. Let's take into consideration everything in your life and let's figure out what works for you and, what's the best treatment for what you have. Well, little by little, the shared decision making went from the doctor and the patient to the health insurance company and their CFO. It started to become sort of the payers in the system started to take over. So there was that, which has, and every year or every couple years, we have more slings and arrows thrown at us that make it more and more difficult to take care of our patients. The other thing that has happened over the years, and if you're, and we're all going to end up being a patient at some point, you may have noticed that there are fewer and fewer what we call private practice independent practices, meaning not employed by a larger conglomerate, whether it's a huge multi-specialty clinic, whether it's a hospital system, whether it's private equity. The physician used to sort of have say-so over how many patients you can see in a day. I mean, I am in an independent private practice, so I can determine how many patients. But, if you're a rheumatologist and told, well, you've got to see 30 patients a day, that is going to affect how well, in my opinion, you can take care of your patients. So the interlopers between the doctor and the patient have, turned into the payers as well as the employers. So those are the two things. I mean, it used to be, I'd say, I think this might be the best medication, the best treatment for you. And so my first question with patients was always, tell me how you're feeling. How long have you had these symptoms? Unfortunately, now the first question is, what's your insurance? And not just the general plan. What kind of plan do you have under that? Because that's going to determine the treatment.
Yeah.
And, and unfortunately, I have to explain that to patients in the beginning.
Yeah. It's, like yourself, I got into the medical industry, but on the vendor side in 1990 as well, with Roche Pharmaceuticals, actually. And it's true. I mean, I used to walk into, you go into a medical arts building outside the hospital, and here's all your physician practices. And they were everywhere. I think like 75, 80% of physicians were independent or, they had their own business, which they all want to be independent small business people. And, what we've seen, especially I would say the last 15 to 20 years, is just the growth of these enormous companies, whether it's a health insurance carrier like a Aetna, Cigna, Blue Cross, whether it's a PBM or a pharmacy benefit manager, which a lot of people still are starting to learn what they are, and they determine pretty much, and I know you're going to talk about it a little bit, the drugs that people can use and what they pay, and that's Express Scripts, Optum, and CVS Caremark. Yep, thank you. And so there are new players, but there are so many more. You mentioned private equity. When something you and I talked offline about was these hospital systems. And, I don't know if we'll get to it. I will in a future podcast. I can promise that we won't touch on it today. But, what the C-suite is being paid, I mean, $5 to $10 million for a CEO. And, they're laying off people in these hospitals. I had a friend, they went to the hospital and they were sitting in the ER on a gurney in a hallway for 7 hours. And hospitals are laying off their employees, and these executives are making $2, $3, $5, $10 million. It's sad. I'm not sorry. That was an article I read recently. I know we weren't going to focus on that.
Yeah. I mean, when you have to limit it to what was it? Mass General, the residents were saying, you need to limit the CEO's salary to 50 times the lowest paid employee here at Mass General. Limit it to 50 times. I mean, when you look at the numbers, they're astounding. And of course, they're all nonprofit because most of them are 340B, but I digress. Right. You're right. That's another program.
Well, one of the things that, and as we talked about, so this podcast is not focused to be targeting healthcare professionals. So we want to really get away from acronyms so that the audience, everybody out there walking, needs to know how has healthcare gotten so messed up in our country? And we're the wealthiest country in the world. How is that possible? And I know that one of the things that I ask people when they tune in is to learn how to be an advocate, which means to fight for a cause. And Mattie, I know, this is how you and I really connected was through your advocacy efforts and going to meetings. So you shared why you got into being a physician and going into medicine. Can you share with everybody real quick what pulled you into advocacy?
Well, you would think that this would be the reason, the thing I'm about to tell you, but that really wasn't it. After I'd been out in practice for about maybe 10 years, my youngest daughter was 9 at the time, and she was diagnosed with what we called back then juvenile rheumatoid arthritis. And so I was able to understand what it felt like to have a family member with a chronic illness. And it's probably worse when it's your child. As we all know, you'd rather have it yourself. So even though that wasn't the impetus, it certainly stayed there as sort of a stalwart whenever I would start to get very cynical about things. And, being part of the medical system, my child had an advantage because I knew how to work the system.
Right.
But most people don't. And so when I became involved with the Coalition of State Rheumatology Organizations, we'll just call it CSRO, they became sort of a premier advocacy arm of rheumatologists. And as I worked in with that organization, I sort of myself became extremely interested in our mission, which is, access to excellence in rheumatologic care for everyone, not just the children of a rheumatologist. And I could see that by working the system, that there were ways that you could actually change the system. And I think the first thing, and we always get into this because we supposedly have a drug pricing crisis. So drug pricing was one of the first things, because let's face it, if it's an expensive drug, and there's different levels of what people consider expensive, but let's just say anything over $100, there's going to be 50, 70% of patients are just not going to go even to the drugstore to pick it up if it's not covered by insurance. In my field, it's rheumatology, but it could be gastroenterology. And obviously cancer, endocrinology, even very expensive antibiotics in infectious disease, asthma, inhalers. There's terrible stories of a poor young man. They stopped paying for his inhaler, so he couldn't pick it up. And a couple days later, he died of an asthmatic attack. So these things that have to do with drug pricing are not just esoteric thoughts of, these are high prices. These affect people's lives, and it can be life and death. And all of that together just sort of said, Mattie, you seem to be pretty good at speaking with people. So keep up with it and try to be part of the change. And sort of all of that together has sort of led me to where I am today.
Well, it's really interesting because, and this isn't unusual for you to know, because when you're in the field, you hear things that most people don't hear. I have another friend, and she helps the Arthritis Foundation. Her daughter had JRA, and that really spurred her to do that. And a lot of people, when I talk to them and I tell them what I used to do, they're like, oh my God, that sounds so complicated. I'm like, it's not. You can write an editorial in a newspaper. You can email your congressperson. There are little things that you can do and not just complain. But to your point, and I know you have certain areas that you specialize in with advocacy, and you've touched on drug pricing, and so I think we'll probably go there. I do want to give you one caveat. While I used to work for a drug manufacturer, I don't work for anybody anymore. So everything's on the table. If you want to call out my old industry, I am more than happy to go down that trail. I've been on a couple interviews already, and we talked about that because there are some things that are absolutely true, and there are some things that people just don't understand, and that's okay. So what are some areas that you're focusing right now?
Yeah. And, when you said, the simplicity of actually becoming involved, and one of the things I think that's probably the most important thing before the everyday person on the street becomes involved in advocacy is a little bit of education and a little bit of knowledge. Because if you really don't know who's a payer, what's an insurance company,
Yep.
What is a formulary? If you've ever gotten insurance, they give you a list of drugs that they'll cover. And most people have no idea what that list of drugs is. And unfortunately, a lot of times the physician doesn't know. So we'll prescribe something and it turns out it's not covered. What that has done is given the power to whoever creates this list, the power to determine what drug you can take, when you can take it, because you may have to take drug A and B before you can get to drug C. So they determine the order. The formulary determines the order that you can take the drug. it determines how much you're going to pay for the drug. Believe it or not, the entity that creates this list tells you which ones, when you can take it. They also tell you how much you're going to pay for it. And now they even tell you where you can go get it. Like, I'm sorry, it's got to be mailed to you. I'm sorry, you can only go to the drugstores that we own. And they're even sort of getting into the business of, if you're going to get a drug by vein, where you can go and get it. So think of this company that has so much power over drugs. They're called pharmacy, drugs that come from a pharmacy, benefits, like how you can arrange these drugs, how we can benefit you, management.
Yep.
Pharmacy benefit managers, otherwise known as PBMs. So these PBMs, if you really think about it, have all the power when it comes to determining the price and what drug you and I are going to pay for it. And as I was alluding to a little bit earlier, if it's an expensive drug, over than $100 a month, and we have in rheumatology now $6,000, $7,000, $8,000, $9,000 a month drugs. If it's not on the formulary and you're a manufacturer of one of these expensive drugs and it's not on the formulary, no one will ever take your drug unless you give it to them for free. So imagine that. We've got all these pharmaceutical companies out there competing, vying to get on this list. Because if you're not on the list, honey, nobody's going to take your drug. Yeah. So the competition to get on that formulary is fierce. And I think people need to understand that, because when I go before legislators, sometimes talking about formularies, the legislators say we need more competition out there between the manufacturers. But again, remember, if you're not on the formulary as a manufacturer, no one's going to take your drug. So the competition is fierce. So why are the prices so high? We think competition brings down prices, right? I mean, I even had a legislator tell me, oh no, we definitely need more competition. That'll bring down the prices in drugs. And again, I'm going to preface it sort of like what you were talking about. I'm not taking the blame from the manufacturers, because absolutely they set the price. No question about it. Yep. But I'm sharing the blame with he who creates the formulary, because here you have all these manufacturers, pick me, pick me, pick me. I want to be the first one. And the PBM goes, which one can we make the most money on?
Yeah.
Yes. That's what the health insurer says. Which ones can we make the most money on? Yeah. Well, they just happen to make more money on more expensive drugs, because to just make it very simple, if you've got a $1,000 a month drug and you're going to give 50% of it back to the formulary maker, and you've got a $5,000 a month drug and you're going to give 50% back to the formulary maker, which one do they make the most money on? Yep. Obviously the 5,000.
They always say our job is to save money. And we used to always say in the industry, well, saving it for who? And I love your point that people need to educate themselves, because if you listen to Wendell Potter, who used to be with Cigna, and he was one of their corporate communication guys, he says that industry spends millions of dollars every year putting out information that is wrong and blaming drug manufacturers who, like you said earlier, they do have some blame. They do that. I don't like branded direct-to-consumer advertising. The patent thickets that they mess with, I don't like that as well. But I will say, to your point, think about this, because for 8 years I did advocacy, but prior to that I used to negotiate with health plans. You and I know that, we talked about it. You're absolutely right. We used to have a drug that we never raised the price more than 9% a year. Our two main competitors would raise their price 18 to 20%. So that they could pay more to the insurance company. And that is how, between 2010 and 2015, drug prices exploded, because the more you raised your price, the bigger kickback you could give. Mm-hmm. And there is right now, they have safe harbor as far as being able to take these kickbacks. And that's what they are, pay to play.
Yeah. And people, if you don't know what safe harbor means, it's a get out of jail free card. For, you can't give kickbacks to get business in medicine, except, back in the 90s, the federal government in their wisdom said, well, let's give the get out of jail free card to insurance companies, and even those that, make the list of drugs that'll be available to patients because it'll bring down the price of drugs. Well, how's that working out? That safe harbor means they can't be charged with the anti-kickback statute. And that has, if you think about it, that has created this perverse incentive for higher priced drugs. And sure, you go, okay, yeah, so big deal now, but insurance covers them. So what's the big deal? Well, let's talk about that formulary and how it can change over the year and how it can put my patients, and because we're all going to be a patient one day, all of us in danger by what is called a utilization management tool. That's a long sort of word for let's change up the formulary to make sure it's profitable. I mean, that's the way I look at it. Utilization management tools are profit tools. I once testified before an Illinois state legislature on what's known as a non-medical switching, ban.
Sure.
Meaning that the formulary can't change unless it's for a medical reason. The PBM can't just say, we don't want to cover this drug anymore because we can make more money on this drug. Well, unfortunately, it didn't quite pass like we wanted, but in explaining to the legislators what the consequences of changing a drug, there was a young girl who was there to testify. I testified, and sure, I could be wonk and, say all these things. But what she said was she had a seizure disorder and she was on a seizure medicine and her insurance covered it. The parents made sure they were on a plan that covered their daughter's epilepsy drugs. And about 2 months into her senior year, the formulary, it wouldn't cover it anymore. They changed it to a drug she had to take multiple times during the day. She started having seizures. She had to be hospitalized. She lost her entire senior year of high school, had to put off going to college because of this. Why? Because they changed it to a drug that they could make more money on. Ugh. And, and acting as if it doesn't make any difference. And I give this example as you're flying, you're in a plane and you're heading to Chicago. And the pilot comes on and says, well, I just wanted to let everybody know that, we're not going to Chicago now. We're going to New York. And I know Chicago really was going to fit in with your plans, and it's always worked out well when you went to Chicago. But we're going to go to New York anyway. We make more money if you go to New York. I mean, I didn't say that. It's just better for everyone if we go to New York. But, if you'd like to appeal that, you could just stay in the air for another 6 weeks and we'll let you know if you can go to Chicago where you wanted to go.
That is
and
hilarious.
That you go, oh, well, that's ridiculous. That would never happen. Well, that's the kind of thing that happens to people who are stable on their medication and the PBM finds a drug that they can make more money on. And believe it or not, they can change the formulary up to 4 times a year. We won in Illinois, but we only won for a year, meaning they could change it from year to year.
It's interesting. I love when we talk because, it makes you think of stories. And first off, one of the few acronyms in medicine that to me really makes sense in drug pricing is non-medical switching, because they are switching for a non-medical reason. And what you always hear insurance companies say or PBMs say is, look, we have to put in these tools, utilization management, you said it, is how they manage how the doctors can prescribe medicine. They have to put it in there so that physicians and patients don't go straight to the most expensive drug, which you and I both know is ridiculous. Because like I used to work with Florida Blue. I can go onto their medical policies right now, and their medical guidelines give you guidelines that you have to use the least invasive, least expensive drugs first till you can move your way up. So it is a true journey. Any patient who's ever gone on a specialty med knows they don't go straight to the specialty med. That's ridiculous. Physicians aren't trained that way, and medical guidelines don't allow for it. It takes 2, 3, 4 years. It takes years to get them, to your point with that young lady, to get to a med that works for her lifestyle, for her biology, and she's comfortable with, and she's already tried so many things. And then I know this for a fact because I used to do it multiple times a year, you're negotiating with health plans or their pharmacy benefit managers. And if they get a better deal, they want to switch people off the drug that they used to be on to the drug with the better deal. to your point, the non-medical switch.
Right.
It
And it's not the better deal for you.
No,
it's not the
never.
better deal for you, the patient. Oftentimes your cost share may actually go up if it's a more expensive drug. And yet it's saving more money. And, the Federal Trade Commission, which is sort of our consumer protection commission,
Yep.
until a couple of years ago, they never met a PBM that they didn't love. I mean, that's how I got interested in PBMs. There was a man, an attorney who used to be an attorney advisor to the Federal Trade Commission back in the 90s. He became sort of this, I don't want to say anti-PBM, but anti-PBM. And he would go, David Balto is his name. He would go before the Federal Trade Commission. And in 2015, I started reading everything that he would present to the Federal Trade Commission. And they would always go, oh, no, we can't have transparency. That softens competition and raises prices. I went to one of their forums one time called a PCMA forum, and there they were. They had people from the Federal Trade Commission all going, PBMs are great. Well, over the last few years, we have had some changes with the Federal Trade Commission, and now they're investigating. How can we give all of this power to just three institutions? And now they're no longer just a PBM. You've got the mothership, which I suppose you could say is the medical side of the insurance company. Then you've got the pharmacy side, and then you've got the specialty pharmacies, and then you've got the banks, and then you've got the subsidiaries that hide money in Europe. And now you've got the subsidiaries that actually co-produce drugs. So they can prefer a drug that they co-produce on their formulary and knock everybody else off. The manufacturers used to try to do that in the 90s, and the Federal Trade Commission said, you can't do that.
Yep.
And yet now we have an insurance company producing a drug and preferring it on its formulary. It has gone topsy-turvy.
It's crazy, Mattie. It's so funny because when I used to do my talks, I would start off and I'm like, okay, I'm Johnson & Johnson. This is when I used to work for them. Everybody's like, oh my God, y'all are huge. And we are. We're the biggest drug manufacturer in the world. Last year, the revenues for Johnson & Johnson were $87 billion. And that's the most of any drug manufacturer out there. United Health Group made $400 billion. And like, oh, that's the biggest one. Okay, the second biggest one, which is CVS Aetna, made $381 billion. Lena Khan, who used to run the FTC, to your point, they finally started doing stuff. She was my superhero. Hopefully the new FTC chair will continue that work and all the investigations. But they have too much power. And if it wasn't hurting people, that's okay. Our healthcare system is a wreck right now. Everybody I told that I'm going to start a podcast, they literally will give me a personal story about how the system has messed them up.
I mean, so we have the drugs. They're in charge of the drugs. And again, what drug, when you can take them, how much you're going to pay for, and where you can pick them up. 3 companies for the entire country. What started off as a good idea, and a lot of you will remember, back when they started things like it turned into what's known as prior authorizations, meaning you had to be authorized to get a particular procedure, authorized to get a particular imaging, authorized to take a particular drug. So not only do you need the prior authorization for the drug, then you have to go through step therapy as well. But they've gotten to the point where, and this is a recent story, where there was a surgeon operating on a woman with breast cancer. And in the middle of the surgery, she had to get a prior authorization so the patient could stay in the hospital overnight because there were some complications occurring. And they pulled her out and said, no, we're not going to pay for it. That is how bad things have gotten.
During surgery.
And then they denied the prior authorization. So they're just not going to pay for her to stay overnight. That's the kind of power these insurance companies have. And it would be one thing if they were actually covering more things. When we see the profits, like you mentioned, United Healthcare, their profits, that means after they've paid for all the healthcare and everything, their profits are still anywhere from $4 to $6 billion every quarter.
Every quarter.
4 to 6 billion. And yet they won't let a woman with breast cancer who's in the middle of surgery, having complications, they won't pay for her to stay in the hospital overnight. How has it come to that?
So I usually talk in terms of revenue, because revenue is actually the expense to the system. And you can hide. I used to be an accountant before I was in medicine. People don't know that. But you can hide profits however you want. Now that they own so many businesses, they'll just upcharge themselves. They'll profit from one business because they're going to have that business charge the mothership more so she can show less profits and pay less taxes. But at the end of the day, there are so many machinations that they do to just create more money and more complexity. They just showed the other day that United did $17 billion in a stock buyback. So basically, everyone, what that means is you're like, well, look, they have to have profit because they have to reinvest. Well, first off, they don't make anything, so they don't have any R&D. But it's when the company buys back stock that will automatically increase their stock price. Well, guess what? Their executives are getting compensated on mainly their stock. So instead of putting that money towards lowering our premiums, they're using it to increase the price of their stock, which means their shareholders are happy, but then their executives are making more money. So why, instead of using that cash to lower our premiums, they're increasing the stock price for their shareholders and for their compensation. It's insane.
Even though most of us are not economists and, most everyone, like I said, we're all going to be a patient. We need to think long and hard about, and I'm a capitalist. I'm a free market person, always have been, and I still am. But the way our healthcare is paid for is not a free market. There's no competition to speak of to bring down prices. We have the wrong kind of competition. There's no transparency. And I remember talking to my son about this. He's an attorney. He's a labor attorney. And he goes, and he's all on my side. And he said, but Mom, I said, all they think about is money. And he said, Mom, they're all publicly traded companies.
Yep.
Their responsibility, their fiduciary money responsibility is to their shareholders, not to your patients. So do we really, is this how we want to cover our illnesses with companies whose motivation is to make money, not to take care of patients? You can go to their website and they have all these pretty sentences. We're patient-centric. We care about the patient. We know your needs. We care for your needs. We da-da-da-da-da-da-da-da. It goes on and on. And the pharmaceutical manufacturers say the same thing.
Yes, they
We're
do.
patient-centric. They're publicly traded companies as well. Their bottom line is their bottom line. So here we've got the drug makers. At least they make drugs. That's the way I look at it. And then we've got the health insurance companies doing everything they can to keep their stock prices up and going higher and higher and higher, not to take care of the patient, not to take care of paying for your health insurance. So I don't know there is no easy answer. We go, well, we have to look to Congress. Well, because these companies are so wealthy, and the insurance companies are all in the top Fortune 15. Right. Along with some other people in the drug supply chain. They give a lot of money to congressmen. They give a lot of money to the people who vote the laws, tell us what it is. So I don't mean to be pessimistic about this, but we do have to sort of nibble around the edges because I know, Chuck, disruption is the word for your podcast. I'm not certain if we can totally disrupt the system.
I look at it, and that is why I had to do this, because to your point, a lot of people don't understand what's happening. And so I retired a little bit early to do it. Yes, there is a lot of money out there with the lobbyists and swaying Congress, but we can all make a difference. And I just saw, that whole Mass General article that we talked about, when you have physicians doing basically a stand-in and going behind legislation to cap the salary of the CEO of their hospital. The quote by the one of the physicians was great. CEOs don't stay up in the middle of the night taking care of patients. They're not in the ICU. They're not handling all the shortages in the hospital. Why are they getting paid so much? It's not, don't hate the player. We talked about this, hate the game. And what do you expect when our legislative officials allow these companies that are supposedly controlling our healthcare system and are supposed to control costs, that their responsibility is to drive a profit and revenue and give that money to shareholders, they're going to do that. So unless they change the game and unless people call their legislators and raise hell, nothing's going to change. It's not.
We've all been insulated from the cost of healthcare, and I've heard, so for example, and we all have this idea that somehow, at least for a while, if the more you spend, like if it's a surgeon that charges $5,000 for a particular surgery and another one only charges $1,000, well, obviously the $5,000 one must be better. I must get better care. I must get better. And because it's only going to cost you, I don't know, $100 for each, people go, well, I want the one that's going to be better. I want the best. I want it now. And I want somebody else to pay for it. That's a three-legged stool that we can't continue to support, right. Unfortunately. Having more skin in the game, I hate that term. And I'm starting to see it happen where you have these sort of independent hospitals where you can get a cash price for something that's much less, maybe even than what your 20% copay, co-insurance is going to be. So I think that's a beginning of actually starting to see what these prices are. And let me tell you, the other big group that's fighting transparency tooth and nail are the hospitals. They don't want you to know how much they charge one insurance company for a colonoscopy, another insurance company, the cash price for a colonoscopy. If you're a family, your health insurance could be $24,000 a year, easy.
Yep.
There are some people that just go without the health insurance and go and get the cash. Yes, you're supposed to have it, but I think we have to somehow find out what the true costs are. And you're not going to like this, but if you keep direct to consumer commercials from drug companies, I testified against this at one point, but I think I'd like it now. I'd like to see the price of the drug, the list price of the drug, and then how much the manufacturer actually gets for that drug. And my husband goes, they're not going to be able to put that in a commercial and stuff. Well, if they want to do a commercial, and neither one, the health insurance companies, the PBMs don't want that, and I'm sure neither do the manufacturers. But let's see how much the manufacturers make on $1,000 a month drug. In many cases, it's only 20%. It's only $200.
Yeah.
So we need to have transparency to know exactly what's going on. Otherwise, I think the game's going to just continue.
It will. One thing, that I saw with legislation, there's good legislation being passed. But the problem is the penalty for not following it is a fine. And these companies that are making hundreds of billions of dollars, that is the cost of doing business. I told someone the other day, you want to pass an effective law? If they break it, then they're kicked out of a class of trade. If you told hospitals, people don't realize this, hospitals for 3 years, they've had that law on the books that hospitals should be providing online what their prices are. Less than 25% of hospitals 3 years later are following those rules. And so instead of fining them, they should do what they do to the drug manufacturers. They say a class of trade basically would be like Medicare, all of Medicare, or all of Medicaid, or all of commercial. So what they would say to drug manufacturers, if you don't do this, you're kicked. All your drugs are kicked out of Medicare or kicked out of Medicaid. And they can't afford to do business that way. If they went to insurance companies, PBMs, or hospitals and said, here's the law, and if you don't follow it, you're kicked out of Medicare, guess what they're going to do? They're going to follow that law. That is an easy fix that they could all do.
Yeah, there's no what we call teeth.
No.
CSRO has helped around the country to pass what's known as step therapy reform, meaning if you're on a particular drug and you're stable on it, you can stay on that drug. The insurance company can't make you change. Or if the drug they want you to take, you've taken before and it doesn't work, you don't have to take it. Why do we need to pass a law for a drug that you've had a reaction to make the insurance company say, okay, you don't have to take it again? Are you kidding me? Anyway, but to do that, you need to have what's known as teeth in it. So if they continue to make the doctor give that drug to you, we'll write the prescription and we'll say the patient had a reaction. I'm not about to let my patient take a drug that they've already had a reaction to, but I'll write the prescription and then say they've had a reaction so they can step over it. But if they don't follow the rules, instead of saying it's $10,000 every time you don't follow the rule, I'm sorry, you can't practice. I'm in New Orleans. You can't practice. You can't underwrite any health insurance in Louisiana. Done. You're out of Louisiana.
So one of the things that I try to do is, look, I know I throw shade on different players in the industry, and I think it's deserved. But I also like to also say, who's doing something right? Who are some good players? So both on a state and a federal level, I know that you work with a lot of legislators. Are you comfortable sharing with who some of the legislators are that are actually, they get it and they're trying to make a difference? Because I think one way for us to get the legislators to start to do a better job in this area is to say who's doing a really good job so the voters know. Do you have anybody specifically?
I've worked with folks in Louisiana, and I will tell you, I'm not even sure if she's still there. This was a couple years ago, a representative by the name of Katrina Jackson. She helped us pass a copay accumulator ban in Louisiana. She said, if I don't care if you have take the money out of the bank, you find it on the floor, rich uncle gives it to you, or it comes from the manufacturer in a copay card, it should count towards your deductible. Common sense. Yep. There is a representative from South Carolina that he's heading up they are having a PBM committee. And we're actually having a conversation with him this evening because he's interested in getting some PBM kind of legislation passed in South Carolina. Heath Sessions is his name. So yes, finding those folks out there that understand that we do have to do something. One thing, if I could give an idea to patients out there, if you want to do one thing that might help, say you've been denied a procedure, a drug, etc. File an appeal. Less than 1% of all denials are ever appealed. And at least 50 to 60% of appeals are reversed. So even if your doctor doesn't suggest it and the doctor says, well, I'm sorry, they denied that, you go, I want to appeal. What do I need to do to appeal that decision? And that in and of itself is one step towards getting the kind of care that you and your physician have decided is the best for you. And if I could do one thing to change the system, at least in terms of drug pricing, I wouldn't say let's get rid of the PBMs, but let's just turn them into what they were originally there to figure out how much, what we call adjudicate the claim, figure out how much and how the insurance company is going to pay for the claim. They don't get to decide anything about what drugs you take. They don't decide that to change things on you. They don't even decide how much you pay for it. And they certainly don't make money from the manufacturers on picking higher price drugs. Those are two things. File an appeal, change the way PBMs are handle drugs.
And I love it. Those are amazing. And you're absolutely right. I try to tie it to, like, if you're going to buy a house, if you're going to buy a car, you don't just accept it. If it's a bad deal, you push back. This is our health. I know I call you Mattie, but Dr. Feldman, thank you so much. You're such a wealth of knowledge. I love that you come from the perspective of a physician who's been practicing for a while and has seen the evolution. I do love that you're not in the healthcare industry from making money as a manufacturer or a hospital, you name it.
I don't do drug talks.
Oh, I know. I used to ask you to do them and you would say no, which is why I don't have any sponsors, because I want to stay independent. But thank you. I know that there's a lot of great people out there trying to make a difference. I think that you're upset about healthcare. You've got to get involved. You have a website called disruptivedialogue.org, and you can go there. Mattie, we've put together letters so people can sign their name for different types of situations, non-medical switching, step therapy, but also links to their legislators. It's not hard.
And if you can go to just put in your search engine CSRO map tool.
Yes.
You can click on your state and find out what type of legislation has been passed that you can use to get the right drug at the right time for the right price.
So, Mattie, great seeing you. Good luck with the fam. I look forward to reading more about you in the paper because you're always testifying. And if there's anything I can do for you, please give me a holler.
Thanks for having me, Chuck. It was a pleasure.
Take care.